What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my pharmacology playlist. Today we'll talk about the medications used to treat seizure or epilepsy, aka anti-epileptic medications. What's the difference between seizure, epilepsy, and convulsions? Today we'll find out the difference among these three. We'll talk about nerve transmission and ion channels. We'll talk about how to manage status epilepticus, as well as how to manage seizure during pregnancy. So click the like button, click the subscribe button, and let's get started. This video is part of my pharmacology playlist, in which you'll find any pharmacology topic you can imagine. This video was made possible because of the great support from Maria. She requested that I make a video on seizure medication, so there you have it. Please say thank you to Maria in the comments. Thank you so much in advance. And thank you, Maria, for supporting my channel. So what are we going to talk about today? What is seizure? What is convulsions? What is epilepsy? What is status epilepticus? It's an emergency situation, by the way. We'll learn about synapses, neurotransmitters, and ion channels that are implicated in seizures. We'll review some topics from pharmacokinetics. Remember that pharmacokinetics is all about absorption, distribution, metabolism, and excretion. Metabolism is by the liver, excretion or elimination is by your kidneys or your gut. Then we'll talk about the seizure medications as well as a quick review. So if you want to understand what this is all about, get a piece of paper and draw this with me. Here is the neuron. What do we have? We have a cell body here, and we have an axons here. Amazing. Now what? Remember depolarization. What was depolarization? Depolarization was when something positive, such as sodium, enters into the neuron. When the positive enters in, the inside becomes more positive, and this is called depolarization, which is activation. Amazing. But what if a positive left the neuron and went outside, such as potassium leaving the chat? As the positive leaves, I get the exact opposite of activation, which is inactivation. Instead of calling this depolarization, we'll call this repolarization or hyperpolarization, which means inactivation. Okay, if a positive enters, it is activation. But what if a negative, such as chlorine, enters into the neuron? Oh, since the positive entry is activation, therefore the negative entry will be inactivation. So when sodium comes in, this is activation or depolarization. When chlorine comes in, this is hyperpolarization, inactivation. When potassium leaves, also hyperpolarization or inactivation. You will learn soon that GABA will open chlorine channels. So GABA does what? Inactivation or hyperpolarization. GABA is inhibitory. When the inside of the membrane is negative, we are inactive. But when positive rushes in, we become active. Some definitions, please. What is epilepsy? Epilepsy has to be chronic, recurrent neurological disorders. Sensory problems, maybe, plus motor problems, maybe, with loss of consciousness. Normally, my brain activity should be asynchronous, non-synchronous. However, a prolonged synchronous depolarization is what we call seizure. And if I have it for a long time, recurrent attack, now we call it epilepsy. So epilepsy is a chronic seizure disorder. What causes seizure? Well, we do not know. Also, everything can cause seizure. Problems in metabolism, glucose issues can lead to seizure. Electrolytes issue, sodium high, sodium low can cause seizures. Magnesium is high, magnesium is low can also cause seizures. Infections can do it, trauma can do it, toxins can do it. It is incurable but controllable. So seizure is a very big umbrella like you see here. If I have chronic recurrent attacks of seizures, we'll call this epilepsy. Chronic, recurrent, unprovoked. Now, just because it is called seizure doesn't necessarily have to be convulsions. Sometimes I'm not shaking at all. Sometimes I'm silent. If I am shaking, we call this convulsions, such as grand mal seizure. But if I'm not shaking, this is petit mal seizure. What do you mean by shaking? What do you mean by convulsions? Intense attacks of involuntary, repetitive muscular contractions. If they last more than 5 minutes and the convulsions do not stop, this is called status epilepticus, and this is now an emergency. What's the definition of seizure, which is the broad umbrella? Paroxysmal electrical discharges of the brain. Sometimes people have loss of consciousness, sometimes they do not. Sometimes I have alteration of perception, maybe with impaired psychic function, and maybe with loss of sensation. What's the definition of epilepsy? This is recurrent, chronic, unprovoked seizures. What's the definition of status epilepticus? Convulsions for more than 5 minutes. This is a life-threatening situation, which requires immediate medical attention. And of course, the medications that we give in an emergency are not going to be oral medications, but instead they will be intravenous injections. So seizure is the big, broad umbrella term. 2/3 of the seizures are convulsive seizures, and only 1/3 is non-convulsive seizure. Seizures could be classified into focal seizures and generalized seizures. What do you mean by focal seizure? I mean it affects only one focus of the brain, one part of the brain, and it will involve only one part of the body. For example, just my right arm is shaking because the problem is in the part of the brain that controls my right arm, for example. But generalized seizure means all over the body because all of the brain is involved. Focal or partial seizures are divided into two subtypes, simple seizures and complex seizures. What do you mean by simple? I mean we have spared consciousness. I did not lose consciousness. But with complex seizures, we have loss of consciousness, abbreviated as LOC. LOL. Sometimes seizures have aura, which is a prodrome of several kinds of symptoms. Could be sensory symptoms, autonomic symptoms, psychiatric symptoms, or motor symptoms. Some auras or prodromes are visual, such as flashing lights in front of my eye. Then the seizure will happen. Or hearing a certain sound or a certain noise, then seizure takes place. Or smelling a certain smell, and then seizure happens. Or having a weird sense of taste, then seizure takes place. How about generalized seizures, which involve all of the body and all of the brain? Here we'll have loss of consciousness, which means they are complex. Some of them have shaking all over the body, tonic-clonic seizures. In French, grand mal seizures. Some of them are all over the body, the entire brain is involved, however, I am not shaking, and these are called absence seizure or petit mal seizure. Then we have other types such as tonic seizures, clonic seizures, myoclonic or atonic, i.e. flaccid seizure. So there you have it, the definitions of seizures, convulsions, status epilepticus, grand mal versus petit mal, as well as epilepsy. Now, which site? Well, partial seizure or focal seizure will involve one focus, but generalized seizures will involve the entire brain. And you gotta understand and know the different functions of the different parts of the brain. For example, the frontal lobe controls execution, movement, thinking, judgment, etc. Parietal lobe, sensory. Remember my imaginary line? Just like this, in front is motor, behind is sensory. So in the parietal lobe we have what? We have sensations like the sense of touch, the sense of pain, temperature, etc. The occipital lobe is for vision, the temporal lobe is for hearing and memory, the cerebellum is for balance and equilibrium. As for the brainstem, especially the medulla, it has 4 famous centers. Heart and lungs, get it in, get it out. Cardiovascular center, respiratory center, swallowing center, and vomiting center. Heart and lungs, get it in, get it out. What causes seizures? Well, we do not know. Also, anything can cause seizure. Ischemia can do it, hypoxia can do it, hemorrhage can do it, inflammation can do it, icterus, kernicterus, jaundice in neonates can do it. Low glucose can do it, high glucose might do it as well, hypocalcemia, hypomagnesemia, hypo or hypernatremia, as well as other issues. And that's why we need to control and correct the underlying pathology if it exists. And that's why we need CBC, CMP, electrolytes to find these abnormalities. EEG will be very important. Why do seizures continue? Why do they prolong? Who sustains a seizure? Re-entry circuits in the brain, re-entry of excitatory impulse, creating a feedback loop. Again and again and again, so the seizure stays with me. Conversely, synaptic fatigue can reduce seizures. Transmission of impulses through the nerve synapse, like this, can get tired over time. Synaptic fatigue is one of the characteristics of synaptic physiology. That's why it ends when it does. So we've just finished the first bullet point. Now let's talk about status epilepticus, which is an emergency situation. What was the old definition? The old definition was continuous, unremitting, unresolving, continuous seizures for more than 30 minutes. That was the old definition. But if you wait for 30 minutes to decide whether status epilepticus or not, the patient would be toast. That's why the definition was changed into for more than 5 minutes. Now, when you change the definition like this, when you lower the cutoff value, what's going to happen to the incidence of status epilepticus? The incidence will increase. And some lovely news journalists and fear-mongers will claim there is an epidemic of status epilepticus in the country. Well, of course, when you change the definition from more than 30 minutes to more than 5 minutes, more people will be counted within your new definition. Why is math so hard? Status epilepticus is an emergency. Neuronal cell death can occur and long-term neurological sequelae may ensue. That's why we need to treat the patient quickly with intravenous medications, not oral medications, because intravenous medications have higher bioavailability. The bioavailability of intravenous medications is said to be very close to 100%. So what should I do? You give benzodiazepines like lorazepam or diazepam. Benzodiazepines are sedatives and hypnotics. Then what? Then you give phenytoin or fosphenytoin. Fosphenytoin is a prodrug that will be metabolized into phenytoin. What if my patient is not responding yet? Then give me phenobarbital. What if the patient is not responding yet? Now it's time to take it to the next level and give a general anesthetic, such as propofol or thiopental. Thiopental, like phenobarbital, is a barbiturate. Remember that toxins can lead to seizure. Remember that vitamin B1 deficiency can lead to seizures, so it's a good idea to give thiamine or vitamin B1 because sometimes the patient is an alcoholic. And if you give glucose to an alcoholic patient without giving thiamine, you will kill the patient. Now let's talk about some neurophysiology, which is the basis to understand pharmacology. Remember again, sodium enters, this is activation. When chlorine enters, as in the GABA channel, this is inactivation. When potassium leaves the chat, this is inactivation as well. So, in epilepsy or seizures, what's happening is that the neuron is super duper hyper excitable. So, how should we treat? Decrease the excitation, decrease the activation, block those sodium channels so that sodium cannot enter. Or enhance the GABA so that the GABA can let the chlorine in and cause inactivation and calm my excited brain down. There is also another way to do it, which is to inhibit calcium channels. Oh, why should I inhibit calcium? Because remember that calcium is the thing that releases the neurotransmitter from the vesicle. This is just one type of calcium channel illustrated here. Reality is way more complex than this, but you get the concept. So I either block the sodium channels, block the calcium channels, or enhance the GABA. Let's talk about neurotransmitters. You know glutamate and aspartate? These are excitatory neurotransmitters. But GABA and glycine are inhibitory neurotransmitters. So how do I treat epilepsy? Get rid of glutamate and enhance the GABA. Get rid of the excitatory and boost the inhibitory to inhibit, i.e. calm down my excited brain. See, pharmacology makes so much sense once we understand what the flip we're talking about. So, the pharmacology hinges around blocking sodium channels, blocking calcium channels, or boosting GABA. There are many different types of GABA, such as GABA A, GABA B, and GABA C. Medications that work on GABA A include benzodiazepines and barbiturates. Both of them can be used to treat seizures. All of the following drugs act on GABA, which is an inhibitory neurotransmitter. Benzodiazepines do it, that's why they are sedatives and hypnotics. They calm you down. Non-benzodiazepines, barbiturates, propofol, inhaled general anesthetics, and more. That's why these medications, the sedatives and hypnotics, can be used for sedation, hypnosis, decrease anxiety, decrease seizure, decrease memory, relax your muscles, and knock you unconscious. Because they do what? They boost GABA. And GABA is what? An inhibitory neurotransmitter. Here is GABA. When you enhance GABA, the chloride channel opens, chloride delves into the neuron, i.e. chloride influx, causing what? When the negative enters into the neuron, it is hyperpolarization or inactivation. Medications that act on GABA-A include benzodiazepines and barbiturates. But what's the difference? Benzodiazepines increase the frequency of chloride channel opening. So they open more often, leading more chloride to enter into the neuron. Conversely, barbiturates increase not the frequency but the duration, i.e. the chloride channel will remain open for a longer period of time. So both benzodiazepines and barbiturates are sedatives and hypnotics. The benzodiazepines increase the frequency of opening of the chloride channels, but barbiturates increase the duration of opening. Either way, you're gonna lead more chloride into the neuron, causing inactivation and hopefully treating the seizure. How do I remember which is which? For barbiturates, it's duration. So just say barbiturates. Barbiturate, duration. And now onto pharmacokinetics. Let's review the kinetics of pharmacology. If you want a more detailed discussion on pharmacokinetics, check out my general pharmacology course on my website medicosisperfectionalis.com. Pharmacokinetics is basically what your body does to the drug, but pharmacodynamics is the opposite. It's what the drug does to your body. Pharmacokinetics, what my body does to the drug. It's basically absorption, distribution, metabolism, and elimination or excretion. So it is ADME, or you can say Adam spelled funny. There are many routes of administration. You can give the drug orally, intravenously, intramuscularly, etc. Intravenous will give you the highest bioavailability, which is around 100%. So intravenous medications have high bioavailability, the highest that you can imagine. Conversely, if I take an oral medication, what's going to happen is after it leaves my gut and goes to the blood, it's going to reach the vicinity of the portal circulation and it's going to go to the liver, and the liver will metabolize it first before sending it to the bloodstream or the peripheral circulation. And this is called what? The first pass hepatic effect or first pass metabolism by the liver. Then it will send it to the blood, and then eventually it will come back to the liver to be metabolized again. And that's why if I have an emergency like status epilepticus, we give intravenous medications, not oral medications, because they have high bioavailability. What's the definition of bioavailability? The relative amount of the drug that reaches the systemic circulation. Here is the story of pharmacokinetics in just one slide. Suppose that you injected me with a drug, so the syringe is now inside my vein, and the drug will be injected to my veins, to my circulation. So it did not cross any membrane, because you already put it here yourself. So there is no crossing of membranes, which means there is no absorption. However, if you give me an oral medication, it has to leave my gut and go to the blood. And in order to do this, you have to cross a membrane. When you cross a membrane, it is called absorption. Okay, whatever. Whether I took it intravenously or orally or intramuscularly, eventually it's going to reach the blood. Then what? Inside the blood, some of the drug or a part of it, a portion of it will be bound to albumin, another portion will be free in the blood. Which one is physiologically and pharmacologically active? The free, unbound form is active. However, the one that is bound to albumin is inactive. And then what? When this albumin carries the drug towards the cell, then it will leave that drug. Hey, you can leave me now and go to the cell. And when the drug goes to the peripheral tissue, it is called distribution. Then after it gets distributed to tissue, it's going to take its effect. It's going to cause me or give me the therapeutic effects and the side effects. You cannot have one without the other. It's like two faces of the same coin. The trick is to try to maximize the therapeutic effects, the desired effects, while reducing the side effects. But remember that when the drug leaves the albumin and leaves the blood and goes to the tissue, that tissue could be what? Could be liver, metabolism, or kidney, elimination. The liver does many things. One of them is to make albumin, which is the protein that will carry a portion of many drugs in the blood. It also secretes a waste product known as urea. So now my blood has albumin and urea. what's going to happen? They will reach the kidney eventually. Urea is the bad guy, so let's get rid of it. This is called elimination or excretion. But albumin is the good guy. Albumin should not be urinated out. Albumin should stay in the blood. That's a good kidney. It is a kidney that does not filter the albumin out. But what if I have kidney disease? Oh, my kidney is screwed. So the albumin will be lost in the urine and I will get albuminuria. Oh, if there is more albumin in your urine, what's going to happen to the level of albumin in your blood? It will be low, which means that kidney disease can lead to hypoalbuminemia or low albumin in the blood. What else can lead to hypoalbuminemia? How about a problem in the factory? Liver disease can also lead to hypoalbuminemia. So whether I have liver disease or kidney disease, I can get hypoalbuminemia. What's going to happen to the albumin level in my blood? It decreases. Which means what? I'll have less taxi cabs to carry the medications around. So the medication will be unable to bind to albumin because I have less albumin. So the drug will be forced to float freely into the bloodstream. And this is more active and therefore more toxic. So hypoalbuminemia can lead to what? Increased drug toxicity. And that's why if you know that your patient has liver disease or kidney disease, you should adjust the dose, i.e. reduce the dose of the medication and give that patient a lower dose than his counterpart with no liver or kidney disease. Pharmacokinetics is ADME, absorption, distribution, metabolism, excretion. Let's talk about metabolism, i.e. biotransformation. Let's transform the drug from one form to another. It is mainly done in the liver. Why do we metabolize drugs? To convert them from something less water-soluble into something more water-soluble, send that more water-soluble thing to the kidney to get eliminated in stage 4. Metabolism of drugs in the liver could convert something active into something inactive, or something inactive to something active, such as prodrug. Example, phosphenytoin becoming phenytoin, or converting active to something more active, or converting active to something toxic. One of the enzyme systems in the liver is called P450, and it's used for, you guessed it, metabolism. It's also known as liver microsomal enzymes. And as you know, enzymes are proteins. These kinds of proteins contain heme. Some medications induce the P450 enzyme system, which means the liver will metabolize other medications faster, leaving less of the medication in the circulation. Conversely, other medications inhibit the P450 system. When I inhibit metabolism of other drugs, what's going to happen? The drug will stay longer in the plasma, causing more toxicities. Famous examples of P450 inducers are phenytoin, carbamazapine, rifampin, barbiturates, chronic alcohol, nevirapine, efavirenz, glucocorticoids, St. John's wort, and griseofulvin. As for the P450 inhibitors, we have quinidine, we have Cipro, we have isoniazid, grapefruit juice, erythromycin, acute alcohol use, indinavir, cimetidine, sulfonamides, SSRIs, calcium channel blockers, and ketonazole. I try to divide them into antifungals. So here's an antifungal that induces, and here's an antifungal that inhibits. Here's an S, so St. John's versus sulfonamides. Here is anti-immunity versus antipeptic ulcer. Here's an anti-HIV medication, anti-HIV medication. Here's chronic alcohol versus acute alcohol. Here's a medication for tuberculosis, another medication for tuberculosis. Since today we focus on anti-epileptics, please remember that phenytoin, carbamazapine, and barbiturates are P450 inducers. Pharmacokinetics is all about absorption, distribution, metabolism, elimination. Let's talk about elimination or excretion. Let's get rid of the drug, usually done by the kidney, but could also be lost in the stool. Some medications are excreted via bile. What is elimination half-life? It's the time needed to eliminate 50% of a given amount of a drug, or the time needed to reduce the plasma level of a drug to 50% of its original value. For example, let's say that you gave me 100 milligrams of drug X, and then we waited 2 hours. After 2 hours, only 50 milligrams of that drug is left in my system. What's the half-life, i.e., how long did I have to wait before I get half of the amount? Answer: the half-life is 2 hours in this case. How about here? Look at those 50 milligrams, wait another 2 hours, they become 25. What's the half-life here? 2 hours. So when you give me the medication, I start up here. This is my plasma concentration, and look what happens. What happens as I eliminate the drug? Its concentration decreases over time. There are two main patterns of elimination. There is zero-order elimination and first-order elimination. The former is known as saturation kinetics. The latter is known as exponential kinetics. Here is a linear relationship, as you see, but this one is an exponential or nonlinear relationship. Linear is also known as arithmetic, and the exponential is also known as geometrical. Saving your money under the mattress year after year will make it grow linearly. But investing money year over year and earning compound interest on top of compound interest will make your wealth grow exponentially. Donating $10 every year is a linear relationship. That's a constant amount being donated every year. But donating half of your wealth every year is an exponential relationship because you are donating a constant fraction, not a constant amount, every single year. So when a constant amount is being lost, this is called zero-order elimination. But when a constant fraction, percentage, is being lost, this is first-order elimination. How do I remember which is which? The one that has fraction with an FR is the first-order elimination, FR. So, constant amount is being lost per year is zero order. Constant fraction or percentage being lost is first order. If I am taking a medication, would I prefer that this medication follows zero-order elimination or first-order elimination? Of course, I will prefer the first-order elimination because a constant percentage is being eliminated per unit time. But with zero-order elimination, a constant amount is being eliminated per unit time, which means if I mistakenly took an overdose, the body doesn't care. The body will still get rid of a constant amount per unit time. So if I take a low dose, same amount is being eliminated. If I take a very large dose, the same amount is being eliminated. So you can imagine that this is why toxicity of a drug in zero-order elimination is more dangerous than that in a first-order elimination. Thankfully, most drugs follow first-order elimination, but there are some medications that follow zero-order elimination, such as aspirin, ethanol, and phenytoin, especially at high doses. Phenytoin is a famous anti-seizure medication, but we gotta be very careful with the dose because it can follow zero-order elimination. And we will talk about the side effects of phenytoin very soon. Next, we have first-order elimination, where a constant fraction of the medication is being eliminated per unit time. So, do I prefer this? Of course, because if I take a low dose, let's say the body will get rid of half of it in the first day. But if I take a high dose, the body will still get rid of half of it in the first day, which is amazing, which decreases the risk of toxicity. Most drugs follow first-order elimination, except if given in very high concentrations, because if you give them in very high concentrations, you will saturate the receptor or the carrier protein, and you will shift from first order to zero order. Remember, first order, a constant fraction is being eliminated, and this is the exponential decay. So, can you look at these two graphs? Let's call this one graph A and this one graph B. Which one is zero order and which one is first order? Please pause and try to answer this yourself. The linear decay is zero order elimination, but the exponential decay is first order. When there is a constant fraction, it's first order. Now let's actually talk about the anti-epileptic medications. Some general rules on anti-epileptic medications. Gradual dose titration is recommended so that I do not overdose unexpectedly. Many patients prefer sustained release of the medications, which also will give me a steady state concentration without being below the threshold or above the threshold. Gabapentin has very slow GI absorption. Please remember that many of these anti-epileptic drugs are excreted or eliminated by the kidney. So if the patient has kidney disease, you need to adjust the doses, i.e. lower the doses of the following medications. These are the ones excreted by the kidney: gabapentin, pregabalin, levetiracetam, vigabatrin, and zonisamide. As for the other anti-epileptic medications, you will need to adjust the dose for patients with liver disease. So how do I remember it? I remember the kidney ones, and everything else is liver. So, what are the kidney ones? Recall that the kidney can remind me of GFR. Oh, that's true. GFR loves, but we will write loves this way, okay? Who's the GFR? The G is gabapentin, okay? How about the FR? Well, that's pregabalin. So it became GPR instead of GFR, okay? What is loves? LVZ. L is levetiracetam, V is vigabatrin, and Z is zonisamide. And there you have it. Everything else is liver. Many of these anti-epileptic drugs have P450 interaction. Many of them induce the P450 enzyme system, except great love, GLV. Who's the G? Gabapentin again. Who's the L? Levetiracetam again. And who's the V? Vigabatrin one more time. You know what? We can change this mnemonic. So who's excreted renally? Great love. And then easy peasy. Peasy means P and Z. So great love, that's the G, L, V. Great love. Easy peasy, P and Z. Great love, easy peasy means kidney. Anything else is liver. Great love means I am not gonna interact with P450. I'm not gonna induce it. I'm not gonna inhibit it. Many medications in medicine love to bind to plasma proteins, especially albumin, in my bloodstream. So if this is my blood vessel right here and I have albumin inside of it, many medications will hug the albumin strongly. And these include phenytoin, valproic acid, and carbamazapine. These are 3 anti-epileptic medications, and I will give you 3 non-anti-epileptic medications, include thyroxine, salicylate, and phenylbutazone, which is not used today. All of these medications love to hug albumin strongly, which means they can be displaced by another medication that also loves to bind albumin strongly. So these medications can kick others from the albumin, or they can get kicked off the albumin. And if they get kicked off the albumin, what's going to happen? They will go to the plasma. They will be freely floating. And when they are free, they are active, increasing their toxicity. Next, don't forget that liver disease or kidney disease can give me hypoalbuminemia. And if there is no albumin to hug the drug, the rest of the drug will go to freely float in the plasma, raising the plasma drug concentration, increasing the desired effects, and of course increasing the side effects, increasing the toxicity. Now let's give a hypothetical example. Suppose that the half-life of the drug is 10 hours, okay? So every 10 hours, the concentration of the drug in my plasma decreases by half. How should I give the drug to the patient in a way, in a pattern that makes the drug within the range of steady state concentration and not fall below the subthreshold or the subtherapeutic level? So here's how you do it. You give a dose every half of the half-life. What does that mean? If the half-life of the drug is 10, you should give a dose every 5 hours, so that every time the drug tries to decrease and get eliminated completely, you add another dose. Tries to get eliminated, you add another dose. Tries to get eliminated, you add another dose to prevent the drug from falling beneath the subtherapeutic level. Here's a lovely summary of the anti-epileptic drugs. Drugs that inhibit voltage-gated sodium channel include phenytoin, carbamazapine, valproic acid or valproate, topiramate, and lamotrigine. Note that phenytoin, valproate, and lamotrigine inhibit not just the sodium channel but also the calcium channel. As for carbamazapine, it inhibits sodium channels only. Then, medications that inhibit the calcium channels include ethosuxamide and valproate again. Lamotrigine could be also written here because lamotrigine inhibits both sodium and calcium channels. Ethosuxamide inhibits only the calcium channels. Which type of calcium channels? The T type in the thalamus, among other areas of the brain. Next, the GABA enhancers include, remember, the barbiturates and the benzodiazepines. Barbiturates will increase the duration of chloride channel opening. The benzodiazepines will increase the frequency of the chloride channel opening. Next, we have medications that inhibit GABA transaminase, which is an enzyme that breaks down GABA. So when I break the breaker, I will end up having more GABA. Oh, boosting GABA. Yeah, who does that? Valproate can do it, and vigabatrin. I mean, look at the name. It has GABA in it. Of course it boosts GABA. Another medication is called T-gabin. Oh, look at the GABA in the name. It inhibits the reuptake of GABA. So if this is my neuron like here, and then this is the postsynaptic neuron, and then I have the receptor for GABA. GABA is here. I want GABA to bind to its receptor. So I will inhibit the reuptake of GABA so that GABA does not enter the neuron again. And instead of going to the presynaptic neuron, it will stay on the postsynaptic neuron, causing its GABA effect. And GABA is inhibitory. That's how you treat seizures. You see this topiramate, it is anti-AMPA glutamate receptor. Glutamate has two types of receptors, AMPA and NMDA. Who's gonna inhibit AMPA? Topiramate. Who's gonna inhibit NMDA? Carbamazapine. Remember that glutamate is an excitatory neurotransmitter. When you inhibit the excitatory, you become inhibitory, i.e. you inhibit the seizure excitation. Let's start by phenytoin, which is a hydantoin, or sodium hydantoin if you're picky. When should we use it? What are the indications? You can use it for focal or partial seizure, as well as generalized tonic-clonic seizure. So partial as well as generalized. Can we use it for status epilepticus? Yes, because we used phenytoin or its prodrug phosphenytoin. This medication is available oral as well as intravenous. Of course, intravenous has higher bioavailability. Does phenytoin cause excessive sedation? Not usually. How does it work? Well, it inhibits voltage-gated sodium channels. That's the most important mechanism. And then if you want to add inhibiting calcium channels, that's also okay. It keeps my sodium channels in the inactivated state. And when sodium is not rushing in, I am decreasing the conduction of action potential, i.e. decreasing the seizures. Remember that many seizure medications can be used to treat cardiac arrhythmias, because what is arrhythmia but a seizure in my heart? What is seizure but an arrhythmia of my brain? That was deep. This quote is not mine. Is it water soluble? Not really. Therefore what? Therefore, I have a variable absorption time in the GI. Usually slow absorption in the gastrointestinal tract. The initial dose for adults is usually between 3 and 4 milligrams per kilogram of body weight. Try not to exceed 500 milligrams because that's too much. And remember, when you give too much, what's going to happen? Zero order elimination, which is dangerous. Because at a certain high dose, you will saturate all of your receptors, i.e. all of the hydroxylation enzymes in my liver. And after that point, just adding a little dose of phenytoin will lead to a huge increase in the plasma concentration and therefore toxicity of phenytoin. So be very careful. So I should not exceed 500 milligrams oral dose. How about intravenous? You should not exceed 5 milligrams per minute. And in the pediatric population, you should not exceed 1 to 3 milligrams per kilogram. What if I gave too much? Well, you go to zero order elimination, which is dangerous. How dangerous? Don't forget that anti-seizure medications are also anti-arrhythmic medications. So I can get what? I can get bradycardia and hypotension and bradyarrhythmia. Okay, what do you want my plasma concentration of phenytoin to be? I want it to be between 10 and 20 micrograms per ml. Is it used for anything else but seizure? Yes, you can use it for arrhythmia, especially digoxin-induced cardiac arrhythmia. 90% of phenytoin likes to bind albumin, which means I gotta be very careful in patients with liver disease who have low albumin, in patients with kidney disease who have low albumin, and in neonates. At low concentrations, less than 10 micrograms per ml, it follows first order. But if you give too much, such as above 10 micrograms per ml, you switch to zero order. And you get this dramatic increase in plasma phenytoin concentration. What are the side effects? It is toxic to the liver. It can lead to hepatotoxicity, especially at high dose. Of course, phenytoin is given to treat seizure, which is hyperexcitability, so that's why it causes CNS depression instead. High doses can lead to hirsutism, gingival hyperplasia, important, lupus-like reaction or drug-induced lupus, allergies such as rash, and pseudolymphoma, which is not a true lymphoma. There is no cancer, just swollen lymph nodes with fever and rash. Phenytoin can interfere with the absorption of vitamin B9, which is folate. This can lead to megaloblastic anemia. Phenytoin can also interfere with vitamin D, leading to rickets in children or osteomalacia in adults. If I overdose, I can get coma, cardiovascular collapse with hypotension and bradycardia, as well as respiratory depression. Phenytoin is not okay during pregnancy. It can be dangerous, causing the fetal Phenytoin syndrome. Can phenytoin lead to nystagmus? Sure. Ataxia? Yeah. Diplopia? Vertigo? Drowsiness? Yes, indeed. Can it cause peripheral neuropathy? Sure. Here is your normal sodium channel. It is resting, then it opens, then it closes, then it rests, etc., etc. What phenytoin does is that it comes to the sodium channel and keeps it in the closed, inactive state. That's how it treats the seizure. And that's how it causes CNS depression. Side effects of phenytoin: the P, pseudolymphoma; the H, hepatotoxicity, gum hyperplasia or gingival hyperplasia, hirsutism, and fetal Phenytoin syndrome. The E reminds me of vitamin B9, which is folate, and vitamin D. Then I have the O, zero-order elimination when I exceed 10 micrograms per ml, and the N is nystagmus. If you want to learn more about fetal Phenytoin syndrome, I've talked about it in a separate video that you will find in my pharmacology playlist. Don't forget that fosphenytoin is a prodrug that can later be converted to phenytoin. Fosphenytoin is given by intravenous infusion to treat the emergency situation known as status epilepticus. Do we love fosphenytoin? Yes, we love fosphenytoin because it has less side effects than phenytoin. Here's a list of medications that can lead to gingival hyperplasia. This is not a comprehensive list, but you need to remember phenytoin, cyclosporin, and calcium channel blocker, anti-seizure, anti-immunity, and anti-arrhythmic. Next, we have carbamazapine. Why do we use it? It can treat partial or focal seizure. It can treat tonic-clonic generalized seizure. It can treat status epilepticus. It can even treat bipolar mania, trigeminal neuralgia, and glossopharyngeal neuralgia. Very important. This medication is only available orally. It has robust, rapid absorption. About 80% of carbamazapine is bound to albumin. Its elimination half-life ranges between 8 hours and 24 hours. Carbamazapine is weird. It induces its own metabolism, #autoinducer, which can result in sudden reduction in its own plasma concentration, which decreases its therapeutic effects. So what should I do? It requires increase in the dose in about 2 to 4 weeks. What does it do? It inhibits sodium channels. What are the possible side effects? Hepatitis again with elevated liver enzymes, CNS depression again. Don't forget that it's autoinducer. It can lead to, rarely, aplastic anemia, which is not an anemia but pancytopenia, low red blood cells, low platelets, and low white blood cells. It can also lead to rash and Stevens-Johnson syndrome, which is a potentially fatal disease. Carbamazapine can also lead to syndrome of inappropriate ADH secretion, because at high concentration, carbamazapine acts like ADH, or antidiuretic hormone, also known as arginine vasopressin. Since carbamazapine is a P450 inducer, it will induce the metabolism of itself plus other medications. Carbamazapine induces the metabolism of valproic acid, ethosuxamide, corticosteroids, antipsychotics, and even anticoagulants, because they use the P450 system. Conversely, medications that inhibit the P450 system will result in inhibition of the metabolism of carbamazapine and increase in the toxicity of carbamazapine. Such medications include cimetidine, diltiazem, verapamil, isoniazid, and erythromycin, as we have discussed before. Carbamazapine can be teratogenic. It causes cleft lip, cleft palate, neural tube defects, cardiac defects, and bladder defects or urinary defects. Next, we have Valproate. It inhibits the sodium channels, the T-type calcium channels, and it even inhibits GABA transaminase, raising GABA, which is inhibitory, to inhibit the seizures. What kind of seizures? All kinds of seizures. It can treat partial seizures. It can treat generalized seizures, whether they are tonic-clonic or absence, grand mal or petit mal. It can even help us in status epilepticus. When it comes to the partial seizures, Valproate is better at suppressing the convulsive partial seizures rather than the non-convulsive partial seizures. Valproate is absorbed quickly by giving it orally. The peak plasma concentration is between 1 and 4 hours. More than 80% of Valproate loves to hug plasma proteins, especially albumin. The elimination half-life is between 7 and 17 hours. Side effects, of course, if you know nothing, just say nausea, vomiting, diarrhea. If you want to add another one, xerostomia. Valproate can also lead to anorexia. It can cause weight gain. That's important. Mnemonic, Valproate with a V will make me overweight with a V. It can lead to hepatotoxicity. There is no shock there. It can lead to pancreatitis, CNS depression, thrombocytopenia, which raises or prolongs the bleeding time. It is also teratogenic. It can lead to neural tube defects, and it can lead to alopecia or hair loss. And when it damages the liver, it can lead to hyperammonemia, increased ammonia in the blood. But the hyperammonemia from Valproate can happen even if the liver was not damaged. Another side effect is fine tremors. Valproic acid can be eliminated as a ketone-containing metabolite. Valproate is capable of displacing phenytoin from the plasma protein binding site, which means Valproate will kick phenytoin off the albumin, increasing the phenytoin side effects. Valproic acid can actually work as a P450 enzyme inhibitor, not an inducer. So all of the previous ones were inducers. We talked about the carbamazapine, the phenytoin, and even barbiturates can induce the P450 system, but not Valproate. Valproate, enough is enough, I'm going to inhibit the P450 system, which slows down the metabolism of other medications such as phenytoin, yet another mechanism by which Valproate increases the toxicity of phenytoin. Valproate can also raise the plasma concentration of phenobarbital, which is a barbiturate. Does Valproate interfere with the action of oral contraceptive drugs? No. Remember when we talked about anti-seizure medications, the ones that inhibit the calcium channel, they inhibit the T-type, i.e. transient type calcium channel in the thalamus to prevent the burst of thalamic activity and to prevent excitation. Classic example is Ethosuxamide. Ethosuxamide inhibits the T-type calcium channels. We use it mainly for absence or petit mal, which is a generalized seizure with no convulsions. Side effects, CNS depression, yet again, blood dyscharesia, so it can lead to anemia, thrombocytopenia, etc. And maybe teratogenic, but usually not as much as the previous ones. Glutamate and aspartate are excitatory, but GABA and glycine are inhibitory. Too much glutamate, I get seizure. Too much GABA, I get no seizure. Therefore, how do you treat seizure? You either inhibit glutamate or boost GABA. Bingo. How do I inhibit glutamate? We'll talk about some medications that are anti-glutamate. But how do I induce GABA? We'll talk about some medications that boost GABA. Some of them mimic GABA, some of them inhibit the reuptake of GABA, and some of them inhibit the metabolizer of GABA. Gabapentin, pregabalin, and vigabatrin are GABA medications. If you're pro-GABA, we can use you to inhibit pain, so they can manage pain, to inhibit chronic pain, neuropathic pain in diabetic people, etc. But if we inhibit you so much, what's going to happen? Weight gain, due to decreased activity and decreased metabolism. And it's not just gabapentin, pregabalin, and vigabatrin, because we also have T-GABA. Look at the GABA in the name, which inhibits the reuptake of GABA. And you shall not forget that phenobarbital, lorazepam, diazepam, clobazam are sedatives and hypnotics. How did they do this? Barbiturate increased the duration of chloride channel opening, but the benzos increase the frequency of chloride channel opening, and the chloride channel is part of the GABA. So you either boost the GABA or inhibit the glutamate. Let's inhibit the glutamate. We have three medications: Lamotrigine, Topiramate, and Felbamate. Topiramate inhibits the AMPA glutamate receptor. Felbamate inhibits the NMDA receptor. How do I remember which is which? Look at the T with the AMPA. Together, this is Tampa, which is a city in Florida. So it is Tampa, and therefore the other one is the other one. We are anti-glutamate. We are anti-excitation. Therefore, you can use us to treat seizure, bipolar, migraine, etc. Side effects. Lamotrigine is nasty. It can lead to rash Stevens-Johnson syndrome, which is potentially fatal. And it is also teratogenic, can lead to cleft lip and cleft palate. When you inhibit excitation, what do you get? Oh, I get inhibition, I get sedation, I get obesity. As for felbamate, it can lead to aplastic anemia, which is a misnomer. It's not just anemia. It's anemia, leukopenia, and thrombocytopenia. So a better term is aplastic pancytopenia. And there you go. Here's a summary of anti-epileptic drugs. Please pause and review. Epilepsy during pregnancy. First of all, there is no such thing as the best medication for seizure during pregnancy. There is no the best medication. It's all about trade-offs, balancing the risk with the benefit. Hey, if I have an epilepsy or a seizure disorder, is this a contraindication to getting pregnant? No. Pregnancy and seizure. If I'm taking any of the anti-seizure medications, they can lead to what? Decreased folate. So folate supplementation is a must at a higher dose than the other pregnant women with no epilepsy. Why is this? Because many anti-epileptic drugs cause folate deficiency. So what should I do? Take a medication that controls the seizures. If we can get the seizure under control with just one medication, i.e. monotherapy, that's amazing. Not just that, we will try to stay on the lowest possible dose. Which anti-seizure medication is the most teratogenic? Valproate is. Which ones have high risk of fetal malformation? Phenytoin, Carbamazapine, and Topiramate. Remember that many anti-epileptic drugs induce the P450, boosting the metabolism of oral contraceptive pills, which decreases the efficacy of oral contraceptives. So, if I'm taking, let's say, Phenytoin and an oral contraceptive pill, well, I can get pregnant. Pregnant even after taking the pill? Yeah, because the pill is being destroyed by Phenytoin, which boosts the metabolism of the oral contraceptive pill. Almost all of the anti-epileptic medications do it, except Valproate. Valproate is not an inducer of the P450 system. During pregnancy, the clearance of Lamotrigine increases. So, if I decide to take Lamotrigine while pregnant, I need to increase the dose of Lamotrigine. What if I have convulsions during pregnancy? What should we do right now? Benzodiazepines intravenously. Lorazepam, for example. Should I give magnesium sulfate? No. Magnesium sulfate is for eclampsia and not for the acute management of seizure during pregnancy. Are anti-epileptic medications contraindicated during breastfeeding? No, they are not. Don't forget that 90% of pregnant women with epilepsy will have an absolutely normal pregnancy. So let's recap. We're trying to use monotherapy during pregnancy. We'll taper the dose to the lowest possible dose. If the patient is seizure-free for the last 2 to 5 years, we try to completely withdraw the drug altogether. But we only do so 6 to 12 months before conception. We need to give folate at high dose, and we need to order maternal alpha-fetoprotein regularly during pregnancy to check for the presence of neural tube defects. What's the medication that we use to treat grand mal tonic-clonic generalized seizure? You can use Phenytoin, Carbamazapine, Valproate, Barbiturates, Topiramate, or Lamotrigine. How about the petit mal or absence seizure? You can use Ethosuxamide, Valproate, or Lamotrigine. How about partial or focal seizures? You can use Carbamazapine, Phenytoin, Lamotrigine, or Topiramate. How about status epilepticus? You start with lorazepam, diazepam. You can add Phenytoin or fosphenytoin. If the patient is not responding, add phenobarbital. If the patient is not responding, switch to a general anesthetic like propofol or thiopental. Thiopental is also a barbiturate, like phenobarbital. And here is the management of status epilepticus once again. This is very important for your exam. And there you go, the best chart for anti-seizure medications of all time. Today we'll learn about seizure, convulsions, epilepsy. We'll learn about status epilepticus. We learned about neurophysiology, pharmacokinetics, the anti-epileptic medications, and the summary table. If you want more pharmacology in your life, I have the complete pharmacology set on my website, medicosisperfectionalis.com, such as my antibiotics course, my cardiac pharmacology course, my neuropharmacology course, and every pharmacology course you can imagine. If you want to learn about ischemic stroke, hemorrhagic stroke, angina, myocardial infarction, arrhythmias, ARDS, and much more, download my emergency medicine high yields course at medicosisperfectionalis.com. There are more than 300 premium videos. If you click the join button and choose the highest tier, you'll find the join button next to the subscribe button. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.